So thank you, Sharif. First of all, I want to thank my friend Jamal Qadir. In his previous presentation, he has covered the majority of my talk. So my presentation, oligometastatic prostate cancer, how much is possible to do. Uh, Now, I want to acknowledge that few of the slides I have taken idea from the ESMO presentation materials, and many of the images I've used from internet. So I always love to start my presentation remembering this great man who was the founder of the organization, Professor ABMF Karim. And in the conventional way, we know that locally advanced prostate cancer moved to disseminated hormone sensitive prostate cancer, and then it becomes disseminated castrate resistant prostate cancer. So this is the summary. On first stage, we have a locally advanced prostate cancer, then we have a disseminated hormone sensitive, and then it is a castrate resistant. But currently, this 3 stage has been moved to 4th stage. That is, after locally advanced, before moving to disseminated hormone sensitive, there is a stage called oligometastasis. So what is this oligometastasis? In 1995, in an editorial, this proposal concept was recommended by Wishbaum and Hellman that there is an intermediate stage between non-metastatic and metastatic stage, which is called oligometastasis. And they have first proposed in 1995, and again, they have revisited with their comment in 2011. So if you look at the definition of oligometastasis, there are heterogeneity of the definition of oligometastasis. So I have taken the help of this paper published in 2017. They have used different study and they have used different parameter to define oligometastasis. And if you look at this, you will see that less than 5 lesion outside pelvic cavity in bone and or soft tissue metastasis was considered as oligometastasis. And if you look at the timeline of prostate cancer progression, you can see that after curative treatment, then salvage treatment, before becoming polymetastatic disease, there is an intermediate stage called oligometastatic state. So what is the oligometastasis situation? It is a limited systemic disease, and it can be from T2 to T4. Gleason can be 7 to 10, PSA may be 50 to 150. And if it is a de novo or recurrent, it could be in lymph node or bone or viscera. And still the work is going on to find out some genomic markers. And the big question is whether we should be treating this patient with systemic treatment or local treatment. And the big question is how to identify this oligometastasis. If you look to the biology of oligometastasis, seed and soil theory is a known concept, but interesting publication by Pitroda et al. For metastatic colon cancer to liver, they have done the mRNA slicing of the metastatic liver lesion, and they have found that the favorable molecular subtype can live 10 years without any systemic therapy, whereas the non-favorable group needs early systemic therapy, which was quite encouraging, and this did make a big noise. And Lugier et al. Supports the hypothesis that development of a specific molecular marker can predict which oligometastatic patient eventually fail to become polymetastatic. And now the T52, ATM, BRCA1, 2, and RB1, all these mutations which are treated as unfavorable or subgrouped by microRNA may be a predictor for identifying the best group for oligometastasis. And above all, we need to understand whether it is a de novo metastasis or a metachronous, that is an oligorecurrence or not. So as we see, there is no good marker, so we need to trust the imaging, and NCCN has shown so many recommended imaging for prostate cancer. So which imaging we need to choose? So we can say that PSMA is the best for all. Choline is very good for lymph node. Fluorine is recommended for bone, but it has a higher false positive report. So if we don't have a PSMA PET, to identify a real oligometastasis is a big challenge. So why PSMA PET? This is a small series publication of 44 patients, and they have shown that when they have done PSMA PET, and they have found that 33 of 44 patients was scanned positive, and 106 out of 175, there was additional new lesions. And in this scan, they have shown that there was 15 distant metastases, and among this 15, 7 could be treated by SBRT. So this is how the role of PSMA can be justified in identifying oligometastasis, and we can shift the patient from treating from palliative to a curative intent. So one may ask that why we want to treat a local treatment to a systemic disease. As we already know that we need to hit the tumor burden at the beginning, both the primary and metastatic site, because we know that metastatic progression is a dynamic clonal process, and clonal tracking reveals that metastatic seeds metastasis is the seeds for future metastasis. And there are some retrospective studies for local therapies, and these all are single center, retrospective, non-randomized systemic therapy. RP was mostly used prostate directed therapies, and many studies suggest that benefit was there from this local therapy. Another series where single center, small number studies, short-term local control was achieved. And here they have used radiotherapy as the primary treatment. So is there any role of radiotherapy in de novo M1 disease? From the SEER database, they tried to identify the candidate for local treatment, and there was a publication in JCO, and they have shown that ADT plus radiation was doing better than non-ADT. That is, local treatment was doing better than no local treatment. And when they have subdivided, they have seen that prostatectomy plus ADT was doing better than ADT alone. And when the radiation dose was more than 65, it was doing better than ADT alone. So below 65 with ADT was not a good choice. Then these two trials, already detailed discussion is done by my friend, Dr. Jamal, where Stampede was a positive trial, Horror is a negative trial for obvious reason, which is the landmark for now, the practice of de novo metastatic patient primary treatment for radiotherapy in low volume disease. So this already Jamal have shown that which group has the survival benefit. And this paper already, this is a meta-analysis, and they have shown that after all this combination, they have shown that there is a 7% improvement in 3 years survival where there is less than 5 metastases. So this is again in favor that in this systemic meta-analysis that we can get some survival benefit. So we can say that according to the APCC consensus meeting, where more than 2/3 voted for local treatment, and